Question 1. A critical care nurse is caring for a patient admitted with disseminated intravascular coagulation, DIC. Which of the following laboratory findings would the nurse anticipate? A. Increased platelet count, decreased D-dimer. B. Prolonged PT/INR and a decreased fibrinogen level. C. Normal PT/INR, normal PTT, and increased platelet count. D. Decreased PT/INR and increased fibrinogen level. Answer, B. Prolonged PT/INR and a decreased fibrinogen level. This question tests your knowledge of disseminated intravascular coagulation, DIC, and its characteristic laboratory findings. In DIC, there is widespread activation of the coagulation cascade, leading to the consumption of clotting factors and platelets. Consequently, the prothrombin time, PT, and international normalized ratio, INR, will be prolonged due to the depletion of these factors, and the fibrinogen level, a key clotting protein, will be decreased. For instance, imagine a sudden demand for building materials in a construction project. All materials get used up quickly, leaving none for basic repairs, similar to how clotting factors are consumed in DIC. Remember that DIC is a complex disorder of both bleeding and clotting, so labs will reflect the consumption of factors. Question 2. A patient with a history of chronic kidney disease is admitted with severe anemia. The nurse anticipates an order for which medication to stimulate red blood cell production? A. Filgrastim. B. Aprelvacin. C. Epoetin alpha. D. Romiplastim. Answer, C. Epoetin alpha. This question focuses on managing anemia in patients with chronic kidney disease, a common critical care scenario. The key is to identify the medication that specifically stimulates red blood cell production. Epoetin alpha is a synthetic form of erythropoietin, a hormone naturally produced by the kidneys that signals the bone marrow to make more red blood cells. Patients with chronic kidney disease often have insufficient natural erythropoietin, leading to anemia. For example, if your garden is dry because the rain isn't coming, you need to manually water it. Epoetin alpha is like that manual watering for red blood cell production when the kidneys can't provide the natural signal. Remember that epoetin alpha directly addresses the underlying cause of renal anemia. Question 3. A nurse is preparing to administer a packed red blood cell, PRBC, transfusion. What is the priority nursing action immediately prior to initiation? A. Administer diphenhydramine prophylactically. B. Check the patient's vital signs and complete a blood product verification with another licensed nurse. C. Ensure the patient has a 22-gauge peripheral 4 access. D. Warm the blood product in a microwave to body temperature. Answer, B. Check the patient's vital signs and complete a blood product verification with another licensed nurse. This question highlights the critical safety steps for blood product administration, a high-risk procedure in critical care. The keyword priority directs you to the most essential action to prevent adverse events. Prior to initiating a transfusion, it is paramount to obtain baseline vital signs and perform a 2-person verification of the blood product against the patient's identification and physician's order to prevent errors. For example, like a pilot's pre-flight checklist, these steps ensure the right product goes to the right patient before liftoff. Always prioritize patient safety through meticulous verification and assessment before starting a transfusion. Question 4. A patient receiving heparin for deep vein thrombosis, DVT, develops a new onset of thrombocytopenia with platelets dropping from 250,000/L to 80,000/L. The nurse suspects heparin-induced thrombocytopenia, HIT. What is the nurse's immediate priority action? A. Increase the heparin dose to improve coagulation. B. Administer fresh frozen plasma, FFP. C. Discontinue all heparin products and notify the physician. D. Prepare for a platelet transfusion. Answer, C. Discontinue all heparin products and notify the physician. This question tests your recognition and immediate management of heparin-induced thrombocytopenia, HIT, a serious complication. The critical clue is the new onset of thrombocytopenia, low platelet count, in a patient receiving heparin. In HIT, the immune system forms antibodies against heparin platelet complexes, paradoxically causing both thrombocytopenia and a prothrombotic state. The immediate priority is to stop all forms of heparin, including flushes, and alert the medical team, as continued heparin use can worsen thrombosis. For instance, if a medication is causing an allergic reaction, your first step is to stop the medication, not to give more or treat only the symptoms. Remember that discontinuing heparin is crucial to prevent further immune response and thrombotic complications in suspected HIT. Question 5. A patient with a severe gastrointestinal bleed has a hemoglobin of 6.2 g/dl and is hypotensive. The physician orders a massive transfusion protocol. The nurse understands this typically involves the rapid administration of which blood products? A. Platelets and cryoprecipitate only. B. Packed red blood cells, PRBCs, and albumin. C. PRBCs, fresh frozen plasma, FFP, and platelets. D. Whole blood and factor VIIA. Answer, C. PRBCs, fresh frozen plasma, FFP, and platelets. This question addresses the components of a massive transfusion protocol, which is activated for patients experiencing life-threatening hemorrhage. The keywords severe gastrointestinal bleed and hypotensive indicate significant blood loss requiring rapid, comprehensive resuscitation. A massive transfusion protocol typically involves a balanced ratio of packed red blood cells, PRBCs, to replace oxygen-carrying capacity, fresh frozen plasma, FFP, to replenish clotting factors, and platelets to support hemostasis. Think of it like a rapid resupply mission during a major battle. You need not just fuel, PRBCs, but also spare parts, FFP, and repair crew, platelets, to keep the system running. This balanced approach helps prevent dilutional coagulopathy and improve survival in severe bleeding. Question 6. A patient is diagnosed with immune thrombocytopenic purpura, IDP. The nurse understands that this condition is characterized by A. An autoimmune destruction of platelets. B. An overproduction of abnormal platelets. C. A deficiency in clotting factors due to liver failure. D. Bone marrow suppression leading to pancytopenia. Answer, A. An autoimmune destruction of platelets. This question tests your understanding of immune thrombocytopenic purpura, IDP, a specific cause of low platelet count. The key to IDP is recognizing its autoimmune nature. In IDP, the body's immune system mistakenly produces antibodies that attack and destroy its own platelets, leading to thrombocytopenia and an increased risk of bleeding. It's like your body's defense system accidentally targeting its own friendly forces. This specific mechanism differentiates IDP from other causes of low platelets or bleeding disorders. Question 7. A patient with a bleeding disorder has an activated partial thromboplastin time, aPTT, that is significantly prolonged. Which of the following conditions is most likely associated with this finding? A. Von Willebrand disease. B. Thrombocytosis. C. Iron deficiency anemia. D. Polycythemia vera. Answer: A. Von Willebrand disease. This question assesses your understanding of coagulation pathway diagnostics, specifically the aPTT, and its relation to bleeding disorders. A significantly prolonged aPTT indicates a defect in the intrinsic or common pathway of coagulation. Von Willebrand disease is a common inherited bleeding disorder characterized by a deficiency or defect in von Willebrand factor, which is crucial for platelet adhesion and also carries factor VIII, an intrinsic pathway clotting factor. Therefore, its deficiency can prolong the aPTT. For example, think of a complex machine where one essential gear, von Willebrand factor, is missing or faulty, affecting multiple interconnected parts of the coagulation process. Recognizing this connection is key to identifying potential bleeding disorders. Question 8. The critical care nurse is managing a patient with sickle cell crisis. What is the primary goal of nursing interventions during this acute phase? A. Administering prophylactic antibiotics to prevent infection. B. Maintaining strict bed rest and minimizing physical activity. C. Managing pain and promoting hydration and oxygenation. D. Preparing for an urgent splenectomy. Answer: C. Managing pain and promoting hydration and oxygenation. This question focuses on the acute management of a sickle cell crisis, a common critical care presentation for these patients. The primary goals during a vaso-occlusive crisis are to alleviate the severe pain caused by sickled red blood cells blocking blood flow, and to address the underlying issues of dehydration and hypoxemia, which contribute to sickling. Aggressive pain management, intravenous fluids for hydration, and oxygen therapy are foundational interventions. Imagine a traffic jam caused by misshapen vehicles. You need to clear the blockage and ensure the remaining vehicles have enough fuel and air to move. Prioritizing pain control, hydration, and oxygenation directly addresses the immediate threats of the crisis. Question 9. A patient is admitted with hemolytic anemia. The nurse understands that a key characteristic of this condition is A. Decreased respiratory count. B. Premature destruction of red blood cells. C. Increased haptoglobin levels. D. Normal bilirubin levels. Answer: B. Premature destruction of red blood cells. This question probes your understanding of the fundamental characteristic of hemolytic anemia. The term hemolytic itself means the breakdown of blood. Therefore, the core feature of hemolytic anemia is the premature destruction of red blood cells, RBCs, at a rate faster than the bone marrow can produce them, leading to a decrease in the overall RBC count. Think of it like a factory producing products, but those products are consistently breaking down too quickly, leading to a shortage. This accelerated destruction is what defines hemolytic anemia and distinguishes it from other types of anemia. Question 10. A patient receiving a blood transfusion develops sudden shortness of breath, urticaria, and a drop in blood pressure. The nurse's immediate action should be to A. Slow the transfusion rate and observe. B. Stop the transfusion immediately and maintain 4 access with normal saline. C. Administer an antihistamine and continue the transfusion. D. Notify the physician after completing the transfusion. Answer: B. Stop the transfusion immediately and maintain 4 access with normal saline. This question presents a classic scenario of an acute hemolytic transfusion reaction, a life-threatening emergency. The keywords sudden shortness of breath, urticaria, and a drop in blood pressure are hallmark signs of a severe reaction. The absolute immediate priority is to stop the transfusion to prevent further infusion of the incompatible blood. It's crucial to maintain intravenous access with a new bag of normal saline to allow for medication administration and fluid resuscitation, but never flush the reaction-causing blood back into the patient. For instance, if you're exposed to a severe allergen, your first step is to remove the allergen, not just lessen its impact. Always stop the infusion at the first sign of a severe reaction. Question 11. A patient with cirrhosis develops petechiae, ecchymosis, and an international normalized ratio, INR, of 3:5. The nurse understands these findings are primarily due to A. Increased platelet production. B. Overactive spleen sequestering platelets. C. Impaired synthesis of clotting factors by the liver. D. Excessive vitamin K intake. Answer: C. Impaired synthesis of clotting factors by the liver. This question links the clinical manifestations of bleeding in a patient with cirrhosis to the underlying pathophysiological cause. The keywords cirrhosis, petechiae, ecchymosis, and INR of 3:5, a high INR indicates prolonged clotting time, point directly to a severe coagulation defect. The liver is responsible for synthesizing most clotting factors. In cirrhosis, the damaged liver loses its ability to produce these essential factors, leading to a coagulopathy and an increased risk of bleeding. It's like a manufacturing plant that's severely damaged. It can no longer produce its essential goods, clotting factors, effectively. Understanding this hepatic role is critical for managing bleeding in liver disease. Question 12. Which lab value is most indicative of ongoing fibrinolysis and is frequently elevated in disseminated intravascular coagulation, DIC? A. Platelet count. B. Prothrombin time, PT. C. Fibrinogen. D. D-dimer. Answer: D. D-dimer. This question targets a specific laboratory marker used to diagnose and monitor conditions involving clot breakdown, especially DIC. The D-dimer is a specific degradation product of fibrin, which is formed when fibrin clots are broken down by plasmin, fibrinolysis. An elevated D-dimer indicates that there is ongoing clot formation and clot lysis, a hallmark of DIC. For example, if you find pieces of broken pottery, it suggests that a pot was made and then subsequently broken. A high D-dimer tells you that fibrin is being formed and then actively broken down, a key process in DIC. Question 13. A patient undergoing chemotherapy for leukemia is profoundly neutropenic. What is the priority nursing intervention to prevent complications? A. Administering packed red blood cell transfusions regularly. B. Instituting strict reverse isolation precautions and meticulous hand hygiene. C. Encouraging a high-protein, high-calorie diet. D. Monitoring for signs of deep vein thrombosis. Answer: B. Instituting strict reverse isolation precautions and meticulous hand hygiene. This question focuses on the highest priority for a neutropenic patient, a common and critical scenario in hematology oncology. The keyword profoundly neutropenic signifies a severely compromised immune system, making the patient highly vulnerable to infection. Therefore, the absolute priority is to prevent exposure to pathogens through strict infection control measures, including reverse isolation, to protect the patient from the environment, and rigorous hand hygiene. Think of it like protecting a newborn baby. You shield them from germs because their immune system isn't fully developed. Preventing infection is paramount, as even minor infections can rapidly become life-threatening in neutropenia. Question 14. A patient with chronic anemia receives regular iron infusions. The nurse should assess for which potential adverse effect of iron overload? A. Hypertension and tachycardia. B. liver dysfunction and heart failure. C. Hypoglycemia and polyuria. D. Bone marrow suppression and neutropenia. Answer B. Liver dysfunction and heart failure. This question addresses the potential long-term complications of iron overload, which can occur in patients receiving frequent iron transfusions or with certain genetic conditions. While iron is essential, excessive amounts can be toxic and deposit in organs like the liver and heart. This accumulation can lead to organ damage, including liver dysfunction, e.g., cirrhosis, and heart failure due to cardiomyopathy. It's like having too much of a good thing. While a small amount of fertilizer helps plants grow, too much will burn and kill them. Monitoring for signs of organ damage and managing iron levels is crucial in patients at risk for iron overload. Question 15. A patient presents with new-onset epistaxis and gingival bleeding, along with a platelet count of 15,000/L. Which intervention should the nurse anticipate immediately? A. Administration of aspirin for pain. B. Preparation for a platelet transfusion. C. Discontinuation of all intravenous fluids. D. Encouraging ambulation to prevent stasis. Answer B. Preparation for a platelet transfusion. This question highlights the critical management of severe thrombocytopenia with active bleeding. The low platelet count of 15,000/L, combined with epistaxis and gingival bleeding, indicates a significant risk of hemorrhage. At such low levels, spontaneous bleeding can occur, and platelet transfusions are often indicated to rapidly raise the platelet count and prevent more severe bleeding. For example, if you have a hole in a water pipe and your water supply is very low, you need to quickly plug the hole and replenish the water. A platelet transfusion is the direct intervention to address the critically low platelet count and control bleeding. Question 16. A patient with a history of intravenous drug use is admitted with new-onset fatigue, pallor, and jaundice. Labs show a positive Coombs test. The nurse suspects A. Aplastic anemia. B. Drug-induced hemolytic anemia. C. Iron deficiency anemia. D. Vitamin B12 deficiency anemia. Answer B. Drug-induced hemolytic anemia. This question presents a clinical scenario linking patient history, symptoms, and a specific diagnostic test to a type of anemia. The key clues are the new-onset fatigue, pallor, and jaundice, suggesting red blood cell destruction, and especially the positive Coombs test. A positive Coombs test indicates the presence of antibodies on red blood cells, which is characteristic of immune-mediated hemolytic anemias. Given the history of intravenous drug use, a drug-induced cause, such as from certain antibiotics or other medications, is a plausible trigger for this immune reaction, leading to red blood cell destruction. It's like a mistaken identity scenario where antibodies incorrectly target the body's own red blood cells as foreign invaders due to drug influence. Question 17. A nurse is caring for a patient post-splenectomy. What long-term complication should the nurse educate the patient about? A. Increased risk of autoimmune disorders. B. Lifelong need for anticoagulation therapy. C. Increased susceptibility to severe infections. D. Chronic thrombocytopenia. Answer C. Increased susceptibility to severe infections. This question addresses a significant long-term consequence of splenectomy. The spleen plays a crucial role in the immune system, particularly in filtering encapsulated bacteria, like Streptococcus pneumoniae, Haemophilus influenza, and Neisseria meningitidis, from the bloodstream. Without a spleen, individuals have a lifelong increased risk of overwhelming post-splenectomy infection, OPSI, which can be rapidly fatal. Think of the spleen as a critical filter in your body's defense system. Removing it leaves you more vulnerable to certain invaders. Patient education on vaccinations and antibiotic prophylaxis is vital for this patient population. Question 18. A patient is receiving warfarin for atrial fibrillation. Which laboratory value is most critical for the nurse to monitor to ensure therapeutic anticoagulation? A. Activated partial thromboplastin time, aPTT. B. Platelet count. C. International Normalized Ratio, INR. D. D-dimer. Answer, C. International Normalized Ratio, INR. This question tests your knowledge of anticoagulant monitoring, specifically for warfarin. Warfarin, Coumadin, is an oral anticoagulant that works by interfering with vitamin K-dependent clotting factors. The International Normalized Ratio, INR, is the standard laboratory test used to monitor the effectiveness of warfarin therapy and guide dosing adjustments, aiming for a specific therapeutic range, e.g., typically 2.0-3.0 for atrial fibrillation. For instance, if you're baking a cake, the INR is like the timer you set to make sure the cake bakes just right, not undercooked or burnt. Keeping the INR within the target range is essential to prevent both bleeding and clotting complications. Question 19. A patient is diagnosed with thrombotic thrombocytopenic purpura, TTP. The nurse anticipates which primary treatment modality? A. Platelet transfusions. B. Administration of high-dose corticosteroids. C. Plasma exchange, plasmapheresis. D. Heparin infusion. Answer, C. Plasma exchange, plasmapheresis. This question focuses on the critical treatment for thrombotic thrombocytopenic purpura, TTP, a life-threatening hematologic emergency. TTP is characterized by severe thrombocytopenia and microangiopathic hemolytic anemia due to a deficiency in the ADAMTS13 enzyme, leading to unchecked platelet aggregation and microthrombi formation. Plasma exchange, plasmapheresis, is the cornerstone of treatment, as it removes the circulating autoantibodies or toxins that inhibit ADAMTS13 and replaces the deficient enzyme. It's like flushing out contaminated fluid and replenishing it with clean fluid to restart a vital system. Platelet transfusions are generally contraindicated in TTP as they can worsen thrombosis, making plasma exchange the definitive therapy. Question 20. A patient with a severe infection develops septic shock. The nurse notes petechiae, purpura, and oozing from 4 sites, along with a rapidly dropping platelet count and prolonged PT/INR. These findings are most consistent with A. Idiopathic thrombocytopenic purpura, IDP. B. Hemolytic uremic syndrome, HUS. C. Disseminated intravascular coagulation, DIC. D. Von Willebrand disease. Answer, C. Disseminated intravascular coagulation, DIC. This question describes a classic presentation of disseminated intravascular coagulation, DIC, in the context of sepsis. The key clues are the severe infection, septic shock, and the combination of widespread bleeding manifestations, petechiae, purpura, oozing from 4 sites, with laboratory evidence of consumptive coagulopathy, rapidly dropping platelet count, prolonged PT/INR. DIC is often triggered by severe systemic inflammation, like sepsis, leading to simultaneous widespread clotting and bleeding due to consumption of clotting factors and platelets. Imagine a factory that suddenly starts producing too many goods while simultaneously running out of raw materials for production. This dual dysfunction of clotting and bleeding is characteristic of DIC. Question 21. A patient with G6PD deficiency develops hemolytic anemia after taking a sulfa drug. The nurse understands that this is due to A. An autoimmune reaction against red blood cells. B. Decreased production of red blood cells in the bone marrow. C. Oxidative stress leading to red blood cell destruction. D. Impaired synthesis of hemoglobin. Answer: C. Oxidative stress leading to red blood cell destruction. This question targets the mechanism of hemolytic anemia in glucose 6-phosphate dehydrogenase, G6D, deficiency. G6PD is an enzyme essential for protecting red blood cells from oxidative damage. In individuals with G6PD deficiency, exposure to certain triggers like sulfa drugs or fava beans leads to oxidative stress that overwhelms the red blood cells' defenses, causing premature destruction, hemolysis. It's like having a defective shield that can't protect you from a barrage of attacks, leading to damage. Understanding that G6PD deficiency causes oxidative damage and subsequent hemolysis is crucial for patient education and trigger avoidance. Question 22. A critical care nurse is managing a patient with anemia of chronic disease. Which of the following is the most common underlying cause? A. Vitamin B12 deficiency. B. Chronic inflammation. C. Acute blood loss. D. Folic acid deficiency. Answer: B. Chronic inflammation. This question asks about the primary cause of anemia of chronic disease, a common type of anemia seen in critical care. Anemia of chronic disease, AD, is typically associated with ongoing inflammatory conditions, infections, or malignancies. The chronic inflammation leads to impaired iron utilization, reduced red blood cell production, and a blunted response to erythropoietin. It's like a constant low-grade fire in a factory that prevents it from efficiently producing its goods. This is distinct from deficiencies or acute blood loss. Recognizing chronic inflammation as the root cause is key to understanding and managing ACD. Question 23. A patient is admitted with a severe allergic reaction to a bee sting, requiring epinephrine. The nurse notes the patient is also on a daily oral anticoagulant. What is a key hematologic consideration for this patient? A. Epinephrine will potentiate the anticoagulant effect. B. Anticoagulants are typically withheld in allergic reactions. C. The patient is at increased risk of bleeding with trauma from the reaction. D. The anticoagulant will protect against disseminated intravascular coagulation, DIC. Answer: C. The patient is at increased risk of bleeding with trauma from the reaction. This question combines elements of emergency care with hematologic considerations, specifically for a patient on anticoagulants experiencing an allergic reaction. The key is understanding that any trauma or injury, even from an allergic reaction's physical symptoms like swelling or scratching, combined with systemic inflammation, can lead to increased bleeding risk for someone on an anticoagulant. Epinephrine itself does not typically potentiate anticoagulants in this context. While the allergic reaction itself might not directly cause bleeding, the underlying anticoagulant greatly heightens the risk if any injury or tissue damage occurs. It's like walking a tightrope with a safety net, anticoagulant, that increases the risk of slipping on its own, especially with external disturbances. Always consider heightened bleeding risk in any patient on anticoagulation, especially during acute medical events. Question 24. A nurse is assessing a patient with suspected pernicious anemia. Which specific symptom, related to neurological involvement, might the nurse anticipate? A. Restless legs syndrome. B. Paresthesias or numbness and tingling. C. Acute confusional state only. D. Seizures. Answer B. Paresthesias or numbness and tingling. This question focuses on a specific, non-hematologic symptom often associated with pernicious anemia, which is caused by a vitamin B12 deficiency. Unlike other anemias, a severe and prolonged B12 deficiency can lead to demyelination of nerves, causing neurological symptoms. Paresthesias, or numbness and tingling in the extremities, are a hallmark neurological manifestation due to damage to the peripheral nerves and spinal cord. It's like a crucial nutrient for nerve health is missing, leading to short circuits and abnormal sensations. Recognizing these neurological signs is critical for early diagnosis and treatment of pernicious anemia. Question 25. A patient with a history of recurrent venous thromboembolism is discharged on long-term dabigatran. What is a crucial piece of education the nurse should provide regarding this medication? A. It requires weekly INR monitoring. B. It has a reversal agent available for major bleeding. C. It should be taken with food to maximize absorption. D. It is safe to take with NSAIDs for pain. Answer B. It has a reversal agent available for major bleeding. This question addresses a vital safety aspect of direct oral anticoagulants, DOACs, specifically dabigatran. While dabigatran does not require routine coagulation monitoring like warfarin, a significant concern with all anticoagulants is the management of major bleeding. For dabigatran, the specific reversal agent idarucizumab, Praxpindi, is available, which is a critical safety feature in emergency situations. This knowledge is important for both the patient and any healthcare provider managing them in an emergency. It's like having an emergency stop button for a machine. It's there for crucial moments when the primary function needs to be immediately halted. Educating patients on the existence of a reversal agent can be reassuring and is important for their emergency care.